Welcome back. Our final presentation of the day is brought to you by Dr. Matthew Goldberg. Dr. Goldberg is the Medical Director at Castle Biosciences and also Assistant Clinical Professor of Dermatology at the Icahn School of Medicine at Mount Sinai. Dr. Goldberg has served as Castle Biosciences Medical Director since August 2020. And prior to joining Castle, Dr. Goldberg was an Assistant Professor in Dermatology and Pathology at the Icahn School of Medicine at Mount Sinai in New York, and retains his affiliation as an Assistant Clinical Professor of Dermatology. Before joining the Mount Sinai Dermatology faculty, he directed dermatopathology education for the MedStar, Georgetown, and Washington Hospital Center for Dermatology Residency Program. And Dr. Goldberg has a background in translational melanoma research and received the Dermatology Foundation Dermatopathology Research Career Development Award for his research in the field of melanoma epigenetics. Dr. Goldberg graduated summa cum laude from Princeton University and received his medical degree from the Icahn School of Medicine at Mount Sinai, where he graduated with distinction in research. Dr. Goldberg completed his dermatology residency at the University of California, San Francisco, and completed a dermatopathology fellowship at the University of Texas Southwestern. Dr. Goldberg will be discussing the role of spatialomics and TissueCypher in today's clinical management of Barrett's esophagus. Dr. Goldberg, pleasure to have you with us today. And without further ado, over to you.
Thank you very much, and thank you for having me speak here today at this conference. And it's a distance from dermatopathology, but the concepts here, I think, translate between different fields. And today, we're really focusing on the role of TissueCypher, the world's first precision medicine test designed to predict future development of high-grade dysplasia and esophageal adenocarcinoma in patients with Barrett's esophagus. And the title here is to discuss the role of spatialomics and TissueCypher in today's clinical management of Barrett's esophagus. So really a pleasure here to join everyone. Here are disclaimers and my disclosures here at the bottom. So Castle Biosciences, by way of background, is a leading diagnostics company that's improving health through developing innovative tests that guide patient care and clinical decision-making across a range of disease states. So Castle Biosciences has a history of developing these diagnostic and prognostic precision medicine tests for the fields of cutaneous oncology, as well as ocular oncology, with tests in the area of cutaneous melanoma, cutaneous squamous cell carcinoma, and uveal melanoma. And now in the gastroenterology field with TissueCypher, this prognostic test fits with Castle's history of innovation and technology advancements to drive improvement in patient care and clinical decision-making. So at Castle, a foundational kind of concept that underpins this suite of tests that are available to clinicians is that we believe that there are limitations with the traditional approaches that clinicians have to develop treatment plans across all of these different disease states that use clinical and pathology factors alone to essentially develop risk-aligned management plans for patients, and that these decision points can be improved by incorporating personalized genomic and proteomic information to address unmet clinical needs in these impactful disease areas. Castle Biosciences' DecisionDx suite of tests have proven this approach of incorporating personalized genomic information for improving clinical decision-making, essentially improving risk-aligned decision-making in the fields of cutaneous melanoma, as well as cutaneous squamous cell carcinoma and uveal melanoma. So these tests really provide clinically actionable information to healthcare providers and to patients to make more informed decisions about treatment plans. Now, TissueCypher adds a new technology platform of AI-driven image analysis and spatial biology that can extract high-dimensional information from tissue biopsies that are obtained through the routine process of esophageal sampling that establish the diagnosis of Barrett's esophagus. It incorporates a prognostic test for these patients who have a confirmed diagnosis of Barrett's esophagus to address the unmet clinical need of improving risk stratification for patients diagnosed with Barrett's esophagus in this area. And so essentially a suite of tests demonstrates Castle Biosciences' commitment to addressing high unmet clinical needs across a range of disease states using gene expression profiling, as well as AI-based image analysis tools to improve clinical decision-making across a range of different disease areas. So the reason that we're presenting today at this conference for talking about digital pathology and precision medicine is that we're at an important moment of transition in the field of pathology, where we're moving from a deeply analog workflow to one that really incorporates digital pathology in the routine course of clinical care. There's not too many tools that we use on a regular day in, day out basis that were developed in hundreds of years ago. And really the light microscope, which is the primary diagnostic tool used by anatomic pathology for the interpretation and diagnosis of the samples taken from patients in clinic. This is an enduring technology that fundamentally was developed in the 17th century and has obviously gone through some improvements, but is an analog workflow that is being transformed by the advent of digital pathology. With whole slide scanners that can take these glass slides and create whole slide scanned images, this is a real revolution that's taking place where there's significant advantages to the practice of pathology, both to the education of pathology, to medical students and residents, as well as clinicians using this information, but also to develop new clinical workflows that use these digital images to improve kind of throughput, efficiency, or quality control in laboratories. And there's significant advantages for developing clinical solutions where you can apply AI-based image analysis to a range of disease states using these digital images once they've been acquired and cataloged. And so when you convert these analog slides to digital images, you can really develop new high-dimensional computational pathology-based tools to address unmet clinical needs across a range of different disease states. So it adds a clinically relevant possibility here for, why move to digital pathology? There's a huge benefit that can run downstream once we have these images acquired. So the computational pathology promise essentially of how we can use these images to address unmet clinical needs follows this kind of schematic that I'll lay out here. What you need to start with is obviously the digital image itself. And so an approach can use different types of source data, whether that's the H&E slide itself or immunohistochemically stained slides or immunofluorescence-based slides. You can create high complexity or high density clinical images upon which you can create and develop validated and actionable clinical tools that can analyze images differently than what can be done by using the human eye and the subjective approach of interpretation alone. You can develop and validate tools that can essentially improve decision-making for clinicians and realize the promise of precision medicine to use the patient's tumor information to address unmet clinical needs, such as risk-aligned management decisions that come with after the diagnosis has been established. And so what this does, you can actually redefine pathology from being a subjective or observational discipline to one that really provides knowledge and engineering discipline to pathology. So you can bring the wealth of information from computational pathology to bear in actionable moments in patient journeys across a range of different disease states. So today I'll be focusing on TissueCypher, which is a clinically validated solution that really demonstrates the power of these digital pathology solutions using AI tools and applied here to patients who are diagnosed with Barrett's esophagus. And TissueCypher essentially extracts more meaningful information from esophageal pinch biopsies that are taken to obtain the diagnosis of Barrett's esophagus on patients who are routed to screening. And it informs risk stratification and subsequently clinical decision-making for these patients diagnosed with Barrett's esophagus in the categories of no dysplasia, indefinite for dysplasia, or low-grade dysplasia Barrett's esophagus. And it's the only available, clinically available precision medicine test that predicts future progression to high-grade dysplasia and esophageal adenocarcinoma in these patients with Barrett's esophagus through this evaluation of the pinch biopsies that are obtained routinely through endoscopy. The output of the TissueCypher assay is a clinically validated 5-year individual risk of progression to high-grade dysplasia or esophageal adenocarcinoma with the purpose of improving the accuracy of risk prediction to inform risk-aligned management decisions. Essentially, TissueCypher is intended to add value to what clinicians and pathologists are doing already in the risk stratification of Barrett's esophagus and improve that accuracy of risk prediction. So I want to spend just a moment here on why Barrett's esophagus is an impactful unmet clinical need for patients. And there's been some discussion of this already today, but essentially the screening that takes place in clinical practice is that individuals often present to primary care or to their gastroenterology with reflux symptoms or chronic heartburn as seen here on the left. And this results in many upper endoscopies that are performed that leads to the diagnosis of the histologic diagnosis of Barrett's esophagus, with about 4 million people diagnosed with Barrett's esophagus in the United States. However, esophageal adenocarcinoma its incidence is on the rise. That's one of the fastest growing cancers by incidence seen here on this figure on the right. And about 20,000 patients are diagnosed each year with esophageal adenocarcinoma. And this is impactful as Barrett's esophagus is the only known precursor to esophageal adenocarcinoma, and this disease state carries a high morbidity and mortality with a less than 20% 5-year survival for patients who are diagnosed with esophageal adenocarcinoma. And so the challenge is really to improve the detection of patients who are diagnosed with Barrett's esophagus and who actually have a high risk of progression to high-grade dysplasia or esophageal adenocarcinoma, because there's a window of opportunity here where early intervention can help reduce the rates of progression to esophageal adenocarcinoma. And in the same token, you can actually identify patients who, although they're diagnosed with Barrett's esophagus, may actually carry a lower than would be predicted risk of esophageal adenocarcinoma, and they can be routed to more risk-aligned management. So what steps do we use today to risk stratify patients? We essentially are using histopathology to establish the diagnosis of Barrett's esophagus, and then we use the grade of the tumor, the presence or absence of dysplasia, to risk stratify patients into those with high-grade dysplasia, seen here in the yellow, low-grade dysplasia or indefinite for dysplasia in the light blue, and no evidence of dysplasia seen here in the dark blue. And this does provide risk stratification for those patients, as patients with evidence of high-grade dysplasia do have a very high risk of progression every year to esophageal adenocarcinoma. And as such, these patients are actually treated with surgical interventions when high-grade dysplasia is found on pinch biopsy. However, the risk stratification for patients with low-grade, indefinite, or non-dysplastic Barrett's esophagus leaves something to be desired, as although the patients with no evidence of dysplasia have a low risk of progression, they actually make up 50% of those patients who do progress to esophageal adenocarcinoma every year. You can see that 63% here in the second circle of patients who progress to esophageal adenocarcinoma are actually initially found to have no dysplasia or indefinite or low-grade dysplasia at the time of their initial diagnosis. And so this identifies a moment where if we could improve the prognostic accuracy, we could direct more risk-aligned care to patients, avoid unnecessary interventions in those who carry a low risk of progression, and target our interventional approaches to prevent the progression to high-grade or esophageal adenocarcinoma to those who carry a higher biologic risk of progression to those endpoints. So TissueCypher endeavors to do this as it's an AI-driven precision medicine test for these patients who are diagnosed with Barrett's esophagus, either no evidence of dysplasia, indefinite for dysplasia, or low-grade dysplasia. And it extracts objective, meaningful cellular, molecular, and morphologic information from the esophageal pinch biopsies that are taken through the practice of routine diagnosis to better inform clinical management decisions for these patients. So the tissue markers, which I'll run through here in the following slides, seen here in this composite image on the right, identify relevant biomarkers in the biologic progression of esophageal adenocarcinoma, and it identifies them based on not only their presence, but also intensity and location in relation to biologically relevant objects and structures. These are converted into these high-dimensional data elements or features to which the TissueCypher algorithm can be applied to produce a risk score from 0 to 10 and a binned risk class of either low risk, intermediate risk, or high risk with associated 5-year risk of progression to high-grade dysplasia or esophageal adenocarcinoma. So when we talk about these biologically relevant biomarkers, the TissueCypher assay is based on 9 protein biomarkers plus a label for nuclei that are stained on the formalin-fixed paraffin-embedded tissues using immunofluorescent probes. And this is, again, the diagnostic material that's used by pathologists at present to establish the diagnosis of Barrett's esophagus. And so you have tumor-specific markers such as P16, P53, or HER2-neu, which are relevant in the progression of esophageal adenocarcinoma, as well as markers of immune function like CD68 as stained for macrophages, COX-2, as well as CD45-Rho, as well as markers of angiogenesis like HIF-1 alpha and lipid metabolism. So together, these markers are actually stained not only for their presence and intensity, but also their relationship to biologically relevant objects and structures. So this is a composite image seen here with different colors, but you can actually identify within this image and using the TissueCypher approach, different relevant structures. So for example, there's multiple masks that can be obtained through these images, which can identify nuclei, cellular borders, presence of cytoplasm, where the epithelial structures are located, where the epithelial nuclei themselves are located, and where the metaplastic epithelium itself, this is where the diagnosis of Barrett's is actually established, as well as a negative image of the tissue stroma around the epithelial structures. And so these composite images can detect, again, not only the presence or absence of these important biomarkers, but their relationship to one another and the relationship to these biologically relevant objects or structures. So bringing to bear the wealth of information from digital pathology images in the context of the patient's biopsy sample itself. And so the TissueCypher assay has been clinically validated to predict this future progression to high-grade dysplasia and esophageal adenocarcinoma in this group of patients with Barrett's esophagus. This data here on this slide comes from the initial development and training of the TissueCypher assay, and it includes a group of patients who went on to progress to esophageal adenocarcinoma or to not progress to esophageal adenocarcinoma over the course of study. And within this group of patients, the TissueCypher assay could identify those with a high-risk TissueCypher score and a low-risk TissueCypher score, seen here respectively in red and black, and creates a meaningfully different, statistically significant separation in risk between those patients who obtained a high-risk TissueCypher score and a low-risk TissueCypher score. And in the table here on the right, the independent prognostic information provided by TissueCypher was also statistically independent from some of the other factors that are used to risk stratify patients today. That would include some of the clinical and pathologic information, such as the patient's age, segment length of Barrett's esophagus, P53 overexpression, as well as other factors such as gender, which are known clinical risk factors for esophageal adenocarcinoma. In the context of all of those factors, the high risk versus low risk score from TissueCypher remains statistically independent, and so can improve the accuracy of risk prediction for this endpoint of developing high-grade dysplasia or low-grade dysplasia through the output of the TissueCypher algorithm. So what does this look like in practice when you bring this type of information to a group of patients with no evidence of dysplasia, so non-dysplastic Barrett's esophagus? So if you look at the pooled data from TissueCypher, which again contains the largest group of studied progressors to high-grade dysplasia or esophageal adenocarcinoma, you see that patients with non-dysplastic Barrett's do have a risk of progression to high-grade dysplasia or esophageal adenocarcinoma over 4 and 10 years. Sorry, 5 and 10 years here at 4% to 8.6% on this graph. And the idea here for clinical management is that those patients who have a low risk of progression to adenocarcinoma are often routed towards reduced levels of surveillance, and those who have a higher risk of progression are routed towards a higher rate of intervention, often with ablation strategies like endoscopic eradication therapy or other surgical approaches to prevent progression of esophageal adenocarcinoma. So TissueCypher, when applied to a group of non-dysplastic Barrett's patients, can actually identify a group of individuals who have a lower than would be predicted risk of progression over 5 and 10 years, 1.3 and 2.7% respectively here, and at the same time identify a group of patients who are at significantly higher risk of progression with 15.9% over 5 years and 44.8% over 10 years, seen here in the up arrows with red. And so this risk stratification, again, is intended to improve the accuracy of risk prediction and identify the group of patients, even though they do not have evidence of dysplasia, to identify those patients who have a lower or higher risk of progression to high-grade dysplasia or esophageal adenocarcinoma. The validation data for TissueCypher has been robust. It's been repeated across multiple independent validation studies that are outlined here in this table. These include some of the leading medical centers here in the United States and Europe, and include high-value data sets as well that have been involved in studies looking at the progression of patients from Barrett's esophagus to esophageal adenocarcinoma. As I mentioned, it contains the largest group of progressors that have been studied to date and represents a strong clinical validity data that supports the use of TissueCypher and its ability to provide this independent risk stratification that I've outlined here. The information is also clinically useful, and the clinical utility data has come out of Geisinger that demonstrate that when clinicians who are currently risk stratifying patients with histopathology alone, when you incorporate TissueCypher into this approach to risk stratify patients, it results in management changes in a significant number of individuals who receive testing. Specifically, it impacts management decisions in up to 55% of the patients who receive testing with TissueCypher. And this impact is actually risk aligned. So those with a low risk TissueCypher score, downstaged or de-escalated interventional intensity, and those patients with a high risk TissueCypher score were upstaged or had escalated intensity of targeted interventions based on the improvement in the accuracy of risk prediction to those who are likely or unlikely to go on to develop high-grade dysplasia or esophageal adenocarcinoma. And this clinical utility information is impactful as it demonstrates that the information is not only valid, but also useful to clinicians to inform management decisions that they're faced with in the clinic today. One of the reasons why I think this is possible is that the actual output of the TissueCypher assay, although it's based on these high-dimensional complex images with the 9 biomarkers and the AI algorithms that I outlined previously, the actual risk score that's presented to clinicians is easily interpretable with the risk score on a range of 0 to 10, the BIND risk here. This is a report for a low risk TissueCypher score, as well as a 5-year probability of progression to esophageal adenocarcinoma or high-grade dysplasia. And so this information presented in a way that's interpretable to clinicians is actually useful not to replace the risk stratification that's done today, but to really improve the accuracy of risk prediction and risk stratification that clinicians use to guide their decision today. So using this schematic of how computational pathology can be applied to precision medicine clinical solutions, propose really that TissueCypher has been designed to transform the risk stratification that we do currently for Barrett's esophagus to leverage the strength of digital pathology source data to use relevant biomarkers stained with immunofluorescence markers to create high-dimensional data sets that's spatially relevant. So in the context of the actual tissue structures, we can identify the presence, absence, intensity, and essentially spatial relationships of these biomarkers in the Barrett's esophagus pinch biopsy, in the esophageal pinch biopsies that we use to establish the diagnosis of Barrett's esophagus today. This information generates clinically validated and clinically useful tests that improve the accuracy of risk prediction that clinicians can actually incorporate into their decision-making to guide their management decisions to essentially produce more risk-aligned management strategies for patients with Barrett's esophagus to improve the outcome of those patients so that those individuals who have a greater risk of high-grade dysplasia or esophageal adenocarcinoma can receive the therapies to which they will likely benefit, and those that have a lower risk of progression can safely de-escalate those interventions as well. So with that, thank you for your attention, and I'll pause here for any questions.
Thank you, Dr. Goldberg. Wonderful overview. Yeah, we have some questions. So, yeah, just from a pathology perspective, why is predicting the progression of Barrett's esophagus so difficult?
Yeah, that's a good question. I think that what we come up against is that there are limitations with the histopathology approaches that we use routinely across a range of disease states. For Barrett's esophagus, one of the primary tools, once the diagnosis of this intestinal metaplasia or Barrett's esophagus has been established, we use the cytological information on the slides that we're evaluating to identify those patients who have dysplasia, who have indefinite for dysplasia or no evidence of dysplasia. And of course, obviously, in this process, you can also identify patients who have high-grade dysplasia or esophageal adenocarcinoma itself. But in the zone of low-grade dysplasia and lower, the predictive power of that presence or absence of the dysplasia is limited. And again, I outlined there that not all patients who even have low-grade dysplasia will go on to develop high-grade dysplasia or esophageal adenocarcinoma. And by the same token, there are patients who have no evidence of dysplasia, so whose histopathology does not show significant atypia, but they do actually go on to progress high-grade dysplasia or esophageal adenocarcinoma. So there's just some limitations to the predictive power of the histologic correlates of dysplasia. And then the other thing is that there's differences in the practice of interpreting these biopsies in the community and at academic centers with sophisticated or experienced GI pathology, so that low-grade dysplasia in one center may not be low-grade dysplasia in another. So there's an uneven playing field there, because fundamentally the assessment or characterization of the dysplasia is subjective and can vary pathologist to pathologist, center to center. And so there's a limit to the ability, visibility into the future, the predictive ability of the dysplasia, and then there's some uncertainty or subjectivity, inter-observer variability component of pathology assessments that varies pathologist to pathologist, community to academic, that the TissueCypher assay can improve upon using this objective image-based analysis tool.
So just to follow up on that, the difference between community and large academic institutions, we've covered this before in some of our other events on community oncology, and do you see that as being a big hurdle in the pathology arena, or is this TissueCypher, is it going to be something that can help allay some of those difficulties that some of the community oncology groups face?
Yeah, it's a great question. I mean, I think that there's a real need to meet patients where they're at, essentially, right? And so the majority of patients who are diagnosed with Barrett's esophagus in this country are diagnosed by community pathologists or general pathologists, anatomic pathologists who are interpreting these biopsies. And there's a great deal of study showing the inter-observer variability of low-grade dysplasia in this setting. And so I think that a tool like TissueCypher can add significant value to those settings. And in addition, there's value to academic centers as well. Some of the validation studies have looked at a comparison to expert pathology review as well. And the independent prognostic information that's provided by the TissueCypher assays does provide independent information that can augment pathology assessment, whether it's done in community or academic center as well. I think the shape of the unmet need may differ based on where the biopsies are taken and where they're analyzed. But from the validation data itself, TissueCypher adds independent value across the range of how these patients are diagnosed today.
Another question here, can TissueCypher be used in conjunction with esophageal brushings or other alternative esophageal biopsy approaches?
That's another good question. I think that in its initial validation and development and subsequent performance studies that I demonstrated today, they're all compared to esophageal pinch biopsy. So the validation data itself is performed on the routine pinch biopsies that are used diagnostically to establish the diagnosis of Barrett's esophagus, and then make that distinction of non-dysplastic, indefinite for dysplasia, low-grade dysplasia. And then that's where TissueCypher has been validated and applied for both the clinical validity and clinical utility. So at present, samples that have been acquired via brush biopsy have not been subject to validation for the TissueCypher assay. It's really the esophageal pinch biopsies. But theoretically, if there are cases that are identified through esophageal brushings to establish the diagnosis of Barrett's esophagus in those appropriate levels of dysplasia, future validation work could take place to evaluate an assay like TissueCypher on the brushings. One of the limitations might be, again, that one of the strengths of TissueCypher is that it identifies the presence or absence and spatial relationship of these biologically relevant markers in the context of the pathologic anatomy itself. So in relation to the epithelial structures, the metaplastic epithelium, the nuclei, et cetera. And so you would need a structure that retains those anatomic landmarks, essentially, because the TissueCypher assay is based on this spatial biology approach about looking at where the markers are present in the tissue itself. And so the concern why additional work would need to be done is that in a brushing, you may lose some of those contours of the anatomic landmarks, as it were, on which TissueCypher is based. But theoretically, as you identify more patients with Barrett's esophagus, the need for risk stratifying these patients will necessarily grow because more patients will be directed to the management strategies that are currently applied in practice to these individuals diagnosed with Barrett's esophagus: routine screenings, that extend for many, many years and indeed a lifetime for these patients, as well as some of the interventional approaches like endoscopic eradication therapy that are done for patients with the higher end of the risk spectrum to prevent adenocarcinoma.
Excellent. Now we have a question from our audience from Patricia. Can you provide a ballpark figure on the pricing for TissueCypher analysis?
So I can't discuss the pricing information at this time, as it depends on the clinical situation, on the coverage specifically for individuals. So I'll defer that question, but I can actually follow up with whoever's asking that question offline, and we can definitely have a more in-depth conversation about pricing here for sure, as it's an important factor for clinical decision making. Castle Biosciences has a sophisticated and robust patient assistance program across the other tests that we offer at Castle Biosciences, really to endeavor to enable clinicians when they're looking to obtain information for patients to bring those tests and bring that information to the clinicians that are requesting it. And so that patient assistance program is also present for TissueCypher assay to essentially, Castle works extremely hard to bring these assays to clinicians who are looking to obtain this information across a range of disease states, and TissueCypher is no exception there.
Excellent, thank you. I'm sure that's a question that a lot of our audience would like to pose and
Sure.
Follow it up, so that's great. And moving on to probably our last question here is, can the foundational technology underpinning the TissueCypher clinical assay be utilized in other clinical indications?
That's another good question, because I think, in the setting of this, Precision Medicine Summit, thinking about digital pathology, a lot of these tools are technically agnostic to disease state. And I think that the spatial biologic approaches that are incorporated in TissueCypher, while the markers and the specific targets are very specific to esophageal adenocarcinoma, the approach of taking biologically relevant proteomic targets applied to the samples that are routinely collected in the process of diagnosis today, and using the tools of machine learning tools, AI tools that we discussed, to essentially enhance the information that you can obtain from the biopsies that you collect already, can be applied to a range of other disease states, not only in gastroenterology, but also back to dermatology or other disease states as well. Because again, these tools of spatial biology exist independent of the disease state themselves and have to be applied based on the biologically relevant pathways of a particular disease state, oncologic, inflammatory, or other. So you have to pick your targets carefully. But this idea of taking the information from the biopsy that you collect already, making it more valuable to inform decision-making for clinicians obtaining these biopsies, and then using that information to answer an unmet clinical need, could be applied to other disease states in GI, as well as other conditions in dermatology as well, or other disease states entirely.
Great. One last question came in. Is the technology FDA approved?
So good question. The TissueCypher lab test is a lab-based test, and so it's performed in a CAP and CLIA certified laboratory owned by Castle Biosciences. And so the tests offered by Castle Biosciences across the range of tests offered are not FDA approved. The regulatory bodies that are relevant to this space are CAP, CLIA, and New York State as well. And as these are lab-based tests, they're only performed at the particular laboratory where they're located. And so the regulations that they follow are through that. And the FDA does not regulate this type of testing because, again, there's no therapeutic or drug as part of the assay itself. And so they're CAP and CLIA approved assays.